Thank you very much for the kind invitation to talk about atopic dermatitis and COVID-19 in the context of the Secure AD registry and other ongoing research efforts. Here are my disclosures. In December 2019, China reported the first case of COVID-19, and we've been battling the coronavirus globally since early 2020. The Secure AD Physician Registry was set up in late March, and the Secure AD Patient Survey followed in June. For today's talk, I'll focus on the Physician Registry. To date, the Johns Hopkins University Corona Center statistics show over 25 million cases and over 800,000 deaths, making the COVID-19 pandemic the gravest health and socioeconomic crisis of our time. Questions that arose right at the start of the pandemic for us as physicians and our patients were: do systemic immunomodulatory treatments influence a COVID-19 episode? And do patients on dupilumab or other novel systemics potentially fare better compared to those on conventional immunosuppressive medication? These were very important questions that, for instance, the European Task Force for Atopic Dermatitis provided guidance on early into the pandemic. And while we cautioned against the use of higher doses of oral corticosteroids, most of our other recommendations were naturally cautious in the light of the uncertainty that remains. Clearly, immune suppression may facilitate viral infection, but at advanced stages of a COVID infection associated with a cytokine storm, a degree of immune suppression may well be beneficial. So it's a double-edged sword, and it's unlikely that the answers are going to be simple. And this is the gap that the Secure AD registry fills, which I lead with Alan Irvine and Phyllis Spools, together with colleagues from the UK, Ireland, Canada, Japan, Taiwan, Spain, and the Netherlands, supported by our International Scientific Advisory Committee, representing the key atopic dermatitis and dermatology organizations worldwide. With regard to the Secure AD eligibility criteria, patients have to have had atopic dermatitis and at least a high suspicion of COVID-19 based on symptoms, if not a positive test. There are no age restrictions, and patients on both topical and/or systemic therapy are eligible to be entered. Patients enrolled in other studies, including open-label extension studies, are also eligible. And we specifically ask for physicians to wait with data entry until the patient has fully recovered. That's important. And to date, we have 145 patients in the registry, predominantly of white ethnicity with an even sex distribution. We have patients across the life course from under 10 years to over 80 years of age. And thanks to the tremendous effort from Andrea Triocozzi, Katie Paris, and other Italian colleagues, most of our patients to date come from Italy, followed by the UK and the US. The vast majority of the 145 patients were either in remission or had mild disease at the outset of their COVID-19 episode, and few flared during their infection. Not surprisingly for this cohort, asthma was common as a comorbidity, and some patients had important other comorbid conditions associated with a higher risk of COVID-19 and infection severity, including cardiovascular disease and diabetes. Based on BMI, we had 9 obese or morbidly obese atopic dermatitis patients, 2 of whom required ventilation. In fact, only 1 further patient required ventilation across the whole cohort. Cutting to the chase now, the systemic treatments. 121 out of 145 patients received systemic therapy, with the vast majority being on dupilumab. 5 patients had combined treatment with either cyclosporin or oral corticosteroids and dupilumab. 11 were on conventional systemics, predominantly methotrexate and cyclosporin. 1 patient was on mycophenolate mofetil. 2 patients had combined conventional systemic therapy, and we also had 5 patients on JAK inhibitors and 1 tralokinumab patient. 3/4 of our patients had a strongly suspected rather than test-confirmed COVID-19 episode. There's no significant difference in the duration of COVID-19 infections between the dupilumab and the conventional systemic treatment group. And furthermore, there's no difference with regard to the frequency of completely recovering from COVID or never having had symptoms, but being test positive between the dupilumab and conventional systemics group. Moving on to the adverse COVID-19 outcomes, 27 patients attended hospital, of whom 3 were hospitalized and ventilated. Interestingly, there was a difference in the risk of hospital attendances, with those on conventional systemics being over 3 times more likely to attend compared to the dupilumab patients. However, the risk estimate was not statistically significant following adjustment for confounders. With more cases in the registry over time, it looks as if this odds ratio will become significant in due course with higher numbers. And just a brief look at other data collection efforts. The Italian COVID registry is the largest registry that has collected data on atopic dermatitis patients during the pandemic. Since February, 1,831 atopic dermatitis patients have been followed up across 35 centers, most of whom are on dupilumab, followed by systemic corticosteroids, cyclosporin and methotrexate, and a few are also on azathioprine and mycophenolate mofetil. Reassuringly, only 16 out of these 1,831 AD patients had a confirmed COVID-19 episode, and only 3 of these were hospitalized. None had any complications. Without going into further detail, the picture is very similar based on other published case series and case reports across Italy and North America. But similar data is currently missing for the conventional systemics. So in conclusion, the risk of COVID and its complications appears low overall in atopic dermatitis patients treated with systemics, but oral corticosteroids should be avoided at high doses because there's evidence that that impairs viral clearance. There's a potential signal for hospital attendances with conventional immunosuppressives compared to dupilumab, but larger numbers are clearly needed and careful adjustment for confounders. More data on conventional immunosuppressives is required. And it's also important to bear in mind that the patients we have data on in our registries are not necessarily representative of atopic dermatitis patients as a whole, partly because we are focusing on the impact of systemic treatments. And other population-based study designs are more suitable to answer additional important questions. For instance, whether the overall risk of COVID-19 in atopic dermatitis patients is lower or higher compared to healthy controls. And I'm thinking, for instance, of primary healthcare electronic records and national registry data. We plan to conduct comparative analyses with other COVID inflammatory disease registries, and our data entry platform is, for instance, very much aligned with the Secure IBD, Secure Alopecia, and SoProtect registries. Finally, I'd like to thank the Secure AD partner organizations and our partner patient organizations for their tremendous support of the study. We need more patients in Secure AD, in particular on conventional systemics, so please register your atopic dermatitis patients with a suspected or confirmed COVID-19 episode. And I'd like to stress that everybody who uploads a case will be a co-author under the Secure AD study team. I've not had time to talk about our Secure AD patient survey, which patients can enter their data into themselves. This is complementary to the physician registry, capturing patients' experiences, something we hope to tell you about at another meeting. Many thanks.